Hi friends, I am Dr. B.B. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicos. Today I am going to discuss about the cardiac rhythm conduction disorders and management. Sinus rhythm. The heart beats and the rhythm is maintained by the impulses in the nerves in the heart. The impulse initiating the cardiac contraction starts from the SCA node. Sinoatrial node lies at the junction of the superior vena cava and the right atrium. From there, through the atria to the AV node, atrioventricular node, at the base of the inner atrial septum, interatrial septum, and from there down to the AV bundle, then to the ventricles. This bundle of specialized conducting system divides into right and left branches which pass down on either side of the interventricular septum and fairly widely beneath the endocardium in a syncytial network which then extends outwards towards the pericardium. The AV node and bundle have a special blood supply from a branch of right coronary artery and hence localized vascular disease may cause a serious impairment of its nutrition and hence the function. The inherent rhythm of cardiac contraction is under the influence of the autonomic nervous system and may be affected by emotion, various vagal and sympathetic reflexes, or by the chemical substances of body like acetylcholine and catecholamines, etc. The normal pacemaker of the heart, the SCA node, has an inherent rate between 60 to 90 per minute, but if it is depressed for any reason like ischemia or reflex vagal stimulation, the AV node takes over the control and initiates the impulse. The ventricles may develop an inherent rhythm if stimuli from SCA node and AV node fail to reach them, as in complete heart block. In this case, the rate is usually 30 to 40. The normal resting heart rate in adults is 60 to 90 beats per minute. In infants, it is usually 120 to 140. Sinus rhythm. It may be sinus bradycardia and sinus tachycardia. Sinus bradycardia. The impulse originates in the SCA node, but the rate is less than 60 beats per minute. Sinus bradycardia may occur in health from predominance of vagal tone and is common in athletes. Still, there are no symptoms and the electrocardiogram is normal. It may occur pathologically also, that is during convalescence from infections, fevers, raised intracranial pressure, myxedema, jaundice, excessive digitalis and myocardial infarction. Excess sinus bradycardia may cause syncope. The term sick sinus syndrome is sometimes used to describe depressed function of SCA node which may be associated atrial tachycardia. Sinus tachycardia. The impulse originates in the SCA node, but the rate is greater than 100 beats per minute in adults. Sinus tachycardia may be associated with exercise or emotion, or it may accompany fear. Pathologically, it is present in thyrotoxicosis, shock, acute hemorrhage, constrictive pericarditis, or cardiac failure. The rate rarely exceeds 160 per minute, and the electrocardiogram is otherwise normal. Sinus arrhythmia. The impulse originates in the SCA node, but the rhythm is irregular. The heart rate increases during inspiration and slow down in expiration. Like this, deep breathing may help in its differentiation from other arrhythmias. This is of no pathological significance and is most commonly seen in the younger people. The electrocardiogram shows rhythmic variations in the length of the cardiac cycle but is otherwise normal. ECG shows varying intervals between the ventricular complexes. Ectopic rhythm. The impulse may originate elsewhere than in the SCA node, maybe in the atria, AV node, or ventricle. It is called the ectopic rhythm and may be regular or irregular. Ectopic beats, extrasystoles. Ectopic beat arises from some abnormal focus in the heart and or really premature beats arising earlier than expected in the cardiac cycle. Extrasystole is a misnomer as except in rare instances there is no extra or additional beat. As the heart muscle is rendered refractory by the ectopic beat, the next impulse from the SCA node usually fails to excite the ventricles and there is a long pause with increased diastolic filling, so that the next normal contraction is augmented. The origin of the impulse is in the atrium, ventricles, or occasionally in the AV node, and can be recognized only by means of electrocardiogram. Ectopic beats in normal heart may be due to over indulgence of tea, coffee, tobacco, or alcohol, or in case of dyspepsia or anxiety. Ectopic beats can also be found in association with the organic heart disease like rheumatic carditis, acute myocardial infarction, and hypertension. They may also be induced by overdose of digitalis. Atrial and nodal ectopic beats are of no pathological significance, though they sometimes precede supraventricular tachycardia. Ventricular ectopic beats are also of no importance, but in myocardial infarction may be precursor of ventricular tachycardia or fibrillation. Symptoms. Usually it is symptomless but usually discovered during a routine examination. Sensitive people may complain of palpitation or a missing beat or a thud due to augment beat following the ectopic beat. Anxiety may be encountered in some people. Diagnosis. Pulse shows a small premature pulse, long pause or augmented beat following the ectopic beat. If the ectopic beat is soon after, there may be no beat and detected by auscultation only. Pulsus bigeminus. The heart beats are usually coupled, means ectopic beat and its compensatory pause succeed a normal beat and usually occurs in digitalis overdose. Sometimes the ectopic beat is so weak, so at wrist The pulse rate is half and auscultation, the ectopic beat is heard. Treatment. If ectopic beats are present and not producing symptoms, he is not informed of and no treatment is required. When the patient complains of palpitation and there is no cardiac disease, no treatment is required, and the patient is reassured of no problem. If the cause is excessive coffee, tea, alcohol or tobacco, advised to stop completely. If there is dyspepsia, investigate it. A tranquilizer like diazepam may be given as a temporary measure. Pulses bigeminous due to digitalis are warning to reduce the dose of digitalis. In case of myocardial infarction with ectopic beat, lignocaine by injection may be required. Atrial fibrillation. Rapid fibrillation waves take the place of normal atrial contraction followed by ventricular contraction. The atrial rate is about 360 to 600 per minute, but the AV bundle can't conduct impulses to that extent, and varying degree of heart block always exists. The ventricular rate is about 100 to 150 per minute, and the rhythm is totally irregular. The condition may be permanent or paroxysmal. Paroxysmal fibrillation is sometimes the precursor of established fibrillation. Diagnosis. The pulse is completely irregular in time and force. Auscultation is good in diagnosis, and the diagnosis is not mistaken. There is pulse deficit, that is 120 at the apex and 100 at the wrist, due to the fact that the weaker beats following a short diastole are not strong enough to the aortic wall. In mitral stenosis, pre-systolic accentuation is dependent on atrial contraction. Disappears with the onset of atrial fibrillation. Treatment. Digitalis is the drug of choice to control the rapid ventricular rate with success in striking improvement. In fibrillation with no underlying cause or fibrillation precipitated by acute infection, myocardial infarction and thoracotomy by using direct current defibrillator or quinidine, which slows conduction and increase the refractory period. Sinus rhythm can be easily restored in treated patients of thyrotoxicosis if could not be controlled by thyroidectomy or antithyroid drugs. In case of mitral stenosis, there is little to be gained from the restoration of normal rhythm, since the arrhythmia is almost certain to return except where fibrillation is followed valvotum. Clot is liable to form in fibrillating atrium, and with the restoration of normal rhythm, there is always the risk of dislodging emboli from left atrium to the peripheral circulation or from right atrium into lungs. In controlling the ventricular rate, if digitalis is not suited, propranolol or proctalol can be used. In case of recent onset, anticoagulation should be undertaken to combat the risk of embolism. Atrial flutter. Atrial flutter is the regular atrial action at the rate of 250 to 350 per minute, and the ventricle usually respond to every other beat. So 2:1 heart block. Sometimes the response is slower, so 3:1 or 4:1 heart block. Occasionally, the degree of a heart block varies so that the rhythm is irregular. It is less common than the fibrillation. Cardiac failure is precipitated, and thromboembolism is less common. Diagnosis of atrial flutter. When the patient has a constant regular tachycardia of 130 to 160 beats per minute and not influenced by posture or mild exercise, it is the flutter. Sometimes atrial waves may be seen in jugular veins, but electrocardiogram is needed to confirm the diagnosis. Flutter waves have a saw-like appearance in ECG and are interrupted by ventricular complexes. Sometimes the ventricular rate may be double or half. Vagal stimulation, that is the pressure over the carotid sinus in the neck, may halve the rate temporarily, but sinus rhythm is not restored. Treatment of atrial flutter. Digitalis should be given in a full dose and it may produce atrial fibrillation or sinus rhythm. Sinus rhythm is usually restored in few days. If not, treatment with quinidine or electrical conversion as for atrial fibrillation is tried. Paroxysmal tachycardia. Paroxysmal tachycardia is the attack of rapid heart action due to regular succession of ectopic beats lasting from a few seconds to several days and may be of following types. Supraventricular tachycardia, atrial, originating in the atria other than at SCA node. Paroxysmal atrial tachycardia. It is the common type, occurs in young people without organic disease. The onset of paroxysm may be influenced by nervousness, but occurs for no obvious reason. Tobacco, alcohol, coffee, gastric distension may be responsible. Atrial tachycardia with AV block. It is the sign of digitalis toxicity, especially if hypokalemia is present. Junctional or nodal, originating in the pacemaker tissue adjacent to the AV node. Ventricular tachycardia. Paroxysmal ventricular tachycardia is much less common and more serious than atrial tachycardia. It is usually seen in people with ischemic heart disease. It may be the immediate sequel of coronary occlusion and precede ventricular fibrillation. It is sometimes caused by overdose of digitalis. Clinical features. Symptoms may be absent if the paroxysm is brief. Suddenly there is a fluttering in the chest, often described as palpitation. Sometimes the attack may be distressing. The heart rate is above 180 per minute and quite regular. The rate is not influenced by rest, posture or exercise. If the paroxysm lasts more than 15 minutes, the patient may pass a lot of urine. It is helpful in diagnosis. Rarely with a diseased heart or in old age, it may lead to heart failure. It may be terminated abruptly by carotid sinus massage. The electrocardiogram may show series of rapidly occurring ectopic beats of supraventricular or ventricular type. The cessation often appears to the patient to be less abrupt than the onset due to a period of sinus tachycardia following the paroxysm. No treatment is required if the attack is of short duration. In other cases, simple sedation may be sufficient. Atrial. Increase in vagal tone may may arrest the paroxysm, and this is most effectively achieved by carotid sinus massage. Only for medical people. The sinus is situated close to the bifurcation of the common carotid artery, opposite the angle of the jaw. The thumb is placed over the position of maximum pulsation, and firm massage applied to the artery and against the spine for not longer than 10 seconds. First on one side, and if necessary then on the other side, but never on both sides together. Mere pressure may be sufficient. The heart should be auscultated, if possible may be monitored by ECG. Simple measures may be sometimes effective, as holding the breath for as long as possible. Valsalva forcible expiration with glottis closed, or Muller maneuver, deep inspiration with glottis closed. Retching or vomiting may terminate, and this may be induced by putting the finger down the throat. Drugs. Proctalol is the drug of choice. Digitalis is given 1 mg intravenously, or an initial dose of 1 mg orally, followed by 0.254 hourly till the attack is arrested or nausea is initiated. Direct current conversion may be necessary if other measures fail. Ventricular. Lignocaine 50 to 100 mg intravenously will terminate most attacks. If the above fails, procainamide at the rate of 100 mg a minute to the maximum of 2 grams by intravenous injection is effective. The injection should be given slowly and stopped if there is a fall in the blood pressure. Direct current conversion is a simple and safe form of treatment. However, prevention of further attacks. Exciting causes should be avoided wherever possible. Digitalis or Proctalol or other uses in reducing the frequency of attacks of supraventricular tachycardia. Ventricular tachycardia may be prevented by lignocaine, procainamide, and quinidine. That's all about the cardiac rhythm and conduction defects, and in the next video I will discuss about some other disease. Thank you.